latest data for journalists. I'm Wayne Sharp, a health media specialist with the Internews Rooted in Trust project. And Internews is one member of the group hosting today's dialogue. It's the Media Task Force of the Eastern and Southern Africa Interagency Working Group for Risk Communication and Community Engagement. I'll be introducing several people today to speak to you. We have a jam-packed program. So we'll get right into it. Of course, you know, we were here with you a couple of weeks ago to get the latest on the Ebola outbreak and the precautions people can take to protect themselves from this deadly disease. Since then, Ebola has spread, so we wanted to revisit this and get the latest information on this threat to people in East and Southern Africa. Now, according to the Ministry of Health of Uganda, there are 60 confirmed cases of Ebola in the region, 24 deaths, 24 recoveries. In this dialogue, we will hear from Dr. Richard Kabanda, Uganda's acting Commissioner of Health Services in charge of health promotion, education, and health communication. He will provide the latest data on the outbreak, and he'll be joined by Sylvia Somariva of UNICEF, who will share the latest community conversations of misinformation and rumors on social media that UNICEF and other groups have been tracking in the ESAR region regarding the Ebola outbreak. As always, if you have any questions, please use the chat box and type them in, and I will do my very best to monitor your questions, and we'll try to ask them of our speakers today. Just to let you know that we will also hear from Dr. Mike Gube of Internews in South Sudan, who will give journalists some advice on how to handle some statements made by Uganda's President Museveni about the Ebola outbreak. Some very complicated, tricky, and perhaps even dangerous statements that have been made. And we will hear from Dr. Mike talking directly to journalists about what can be done in dealing with that kind of material. But to begin with, I would like to ask Sylvia Somariva of UNICEF to share some of the latest social media content UNICEF and other groups have found in the ESAR region regarding Ebola. Sylvia, welcome back to the dialogue.
Thank you, Wayne. It's great to be back. Hi, everyone. I share a couple of slides just to share what are some of the insights into digital conversations related to Ebola over the past few days. So these are just for context related to the social listening monitoring that we have been doing, trying to track what are the concerns or the information or misinformation that's being shared on digital platforms around this topic. So key trends in digital conversation over the past week, you can see, of course, there has been an uptick in engagement over the weekend, particularly after the president's speech in relation to restrictions and, of course, the lockdown news related to the districts of Mubende, Kasanda. We have seen several users questioning the need for the lockdown and curfew as public health measures, while also seeing an uptick in content denying the existence of Ebola, claiming it is an excuse for the lockdown or for additional police intervention, as well as that it is an illness that's witchcraft related and not actually Ebola itself. So we are monitoring this type of claim closely, and of course we're seeing them also in the previous few weeks. There have also been concerns related to how the movement restrictions are impacting schools and learners ahead of exams, as well as pregnant women who need to access antenatal care. So users expressing questions as to how they can access care, particularly if they're close to the end of their pregnancy. In terms of narratives to watch, we're seeing some conspiracy claims and misinformation going around on Ebola vaccine trials. For example, we're seeing some disinformation narratives that are largely based on COVID vaccine narratives. For example, they claim that lockdowns are a precursor for mass vaccination with untested vaccines, and questions related to sort of what are the motives behind these vaccine trials. We're seeing some rumors related to the number of cases some reports that the numbers are exaggerated, misinformation related to where cases are. And we see occasionally local authorities sort of responding, trying to clarify where the cases have actually been tracked. We're seeing also content on social media related to police interventions and brutality in lockdown areas. These are generating a lot of engagements, and they are often accompanied with videos or pictures. And sometimes these are not from verified sources. So, for example, you may have seen a picture that was going around in the past couple of days of a man with injuries. And when just verifying using Google reverse search, you could see that actually the picture is from South Africa from a couple of years ago. So just some sort of need to be careful with sources and information that's going around on this. And then finally, we have been seeing some content sort of comparing the Ebola outbreak with COVID, saying that COVID is much more severe because there have been more deaths related to COVID. And so we're monitoring how this can impact risk perception and preventing behavior uptake. In terms of potential information voids, we're seeing some questions that keep rising on Google Trends. So people want to know sort of what are the number of cases or number of deaths, what is the situation in Kampala specifically, transmission modalities, clinical trials, vaccine trials, as I mentioned before as well, and treatments and symptoms. So these are issues that keep sort of coming back in the questions that we're seeing, even though we're, of course, seeing increasing information related to this being shared by partners on social media. So these are all the updates that I have. Thank you, Wayne. And of course, if there are any questions, I'm happy to answer. Over.
Thank you so much, Sylvia, for that update, that interesting data. Now, I'd like to introduce to you our keynote speaker. Dr. Richard Kabanda is a public health specialist with expertise in health promotion and disease prevention. And currently, he is Uganda's acting commissioner of health services in charge of health promotion, education, and health communication. Dr. Kabanda previously worked as a lecturer at the Faculty of Health Sciences at Uganda Martyrs University and was head of health promotion and health education at Masaka and Rakai districts' local governments. Dr. Kabanda, thank you so much and welcome to the dialogue. And I think we might have, there you are. Hello.
Yes, do you hear me now?
Yes, we can hear you now. Welcome.
Thank you. I hope my screen is visible. I'm sharing some key slides and some of the key issues or concerns arise from what our colleague has presented. And most of the key issues presented are factual, based on the feedback we have on ground. I will start by indicating that that slide indicates our current statistics in regard to EVD in the country. So as of now, the cumulative confirmed cases are 61. Please note that this slide does not present probable cases. I'm only presenting confirmed cases. So the active cases on admission are 10. The cumulative death as of now are 25. So that gives us almost a case fatality rate of close to 45%, or around 40%, the case fatality rate. But of course, also our surveillance officers or teams across in all the high-risk districts are following up more than 1,500 people. And the good news is that we have so far had 24 people who have recovered. And these have been discharged and they have been accepted back in the communities. So this slide indicates districts where we are having more cases. Of course, Mubende is almost 131 kilometers away from Kampala, the capital city in Uganda, and that's where the epicenter is. So as of now, Kampala is still safe. We have not had any case from Kampala or within Kampala metropolitan area. There are so far 5 districts where we have had confirmed cases. So this geographical map indicates the distribution of cases and where they are coming from. And it's just very clear that Mubende district is the epicenter. You will be able to realize that the faraway districts of Nyangabu and Kagadi, where we have one case, it's clear that one of the health workers who was in contact with the index case, an intern doctor, traveled to Nyangabu and turned out to be positive from there. So, and was treated, is one of those health workers who provided care to the index case. So our approach to controlling the epidemic, the approach is mainly based on a number of technical pillars which are driving, and I'm the one responsible heading the public health risk communication, community engagement, community of practice pillar for Ebola. But of course also for COVID, I was still heading the pillar. And of course, you know that this is our 6th time as the country when we are preparing for the Ebola response. And so the surveillance also have the surveillance and contact tracing pillar, which is much more concerned with community surveillance, contact listing and tracing, and the management of alerts. The other one is case management, which is more into provision of clinical care and psychosocial support, and emergency medical services, as well as infection prevention and control, including WASH. Laboratory and logistics as other pillars. We have also other non-technical pillars, but which are very instrumental in delivery of services currently within the response. And one of them is the one for human resource, and the other one is the one for coordination, because coordination, whenever you have epidemics like the way we have Ebola now, you always have very many partners on board and many institutions and organizations that want to be part of the response. So coordination is one of those key areas. So we have had, in terms of briefly, the high-risk audiences, which I would like to take you briefly. We have, of course, Ebola patients, suspects, and survivors. Those of you who have been following literature that has been published from countries that have gone through this, you know that we need to pay a lot of attention to survivors, especially the male survivors, because there is quite a lot that is still unknown about the male survivors. Families and individuals with previous direct contact with known Ebola case. We have a number of communities in hotspot areas, including refugees. The transport sector in Uganda, we have what we call the border borders. These are people who use motorbikes. It's very common, and many of them keep on transporting people from rural communities to business centers and so on. The other key area which is of concern here among the high risk, I'll only talk about 2. One are the health workers, because we have had many people from private health facilities, since most of the patients, when they get some symptoms and signs, run private facilities because they are closer. And so we take all those, especially in high risk, this to be high risk. And then lastly are the traditional healers. Because many people, as our colleague from UNICEF presented, as Sylvia presented, many people tend to think that maybe they are bewitched or all that, and then they end up not going to health facilities, so they go to traditional healers. So among other high risk, those are the core high risk groups or audiences which we need to focus on, or which we have been focusing on, and our interventions are geared towards them. Since this engagement is for the media, I thought that it's prudent for the media to know where they contribute. Their contribution is more within the area of public health risk communication and community engagement, and we need their support in rolling out the risk communication interventions, in increasing awareness and the risk perception, and of course also to set the agenda to ensure that we trigger public to be able to focus and have more concern on Ebola virus disease. And then the other issue is to rally community leaders to be behind the response and ensure that the interventions that are designed by the technical people are well addressed. The other component is much more centered on public relations, which I think that the media also supports so much. Still on media, I highlighted a number of things which we have tried to do here. We have had some orientations with them. Still with support from UNICEF, we are going to have another orientation with the bigger group at national level next week on Monday, probably. And then also we have tried to ensure that we provide them with information packs, talking points, and press briefs to ensure that they keep on engaging the public from a more informed point of view. I will not go into the behavioral outcomes here, but we would like to ensure that members of the media are knowledgeable, because if they are knowledgeable, they can be able to counter myth and misconceptions timely. So we have also been able to provide talk show guides for the media people so that they're able to engage the technical people and other key stakeholders in a more guided manner. We have produced a number of materials for them, which we think that they can be used. Fact sheets, talking points, and a number of things. So because of time, my conclusion is this is an epidemic like this one, especially for EVD, for Ebola. We need to make sure that we have everybody on board. The response is mainly controlled by having communities fully owning the response. And it's a multidisciplinary kind of engagement in terms of having technical teams that engage with the communities. If you look at the different pillars and the expectations, so we need everybody on board, whether within or across. And the other key issue, which I can also end with here, is in line with the number of social cultural drivers of community resistance for the Ebola response strategies. The number of drivers, which many people need to pay attention to. And of course, our medical anthropological teams have been able to extract a lot of information, which we used from time to time to be able to engage communities better and be able to have our interventions structured in a manner that engages the community. Thank you for listening to me.
Thank you so much, Dr. Kabanda. I'm really excited to see that you have prepared some talk show guides. I think that's really great that you're providing some advice to the media on how they can address the Ebola issues. We have so many questions here from our participants. So I mean, some of this is going to go back to basic info, but I think it's important to cover this ground. We have Maluk, he's with the Agamlong National Daily newspaper in South Sudan. And his question is for you, Dr. Kabanda, is how can a person get infected with Ebola, and what environmental conditions does Ebola need to survive?
I beg your pardon on the question?
The question is, how can a person get infected with Ebola, and what environmental conditions need to be in place for Ebola to survive?
I don't know if I've got the question right. The transmission.
Okay, how does a person get infected with Ebola? How does it happen?
Okay, somebody gets infected with Ebola when he or she has been in contact with somebody who has Ebola, but that person must be having signs and symptoms. So if somebody is non-symptomatic, that person cannot be able to spread. And even if somebody is having Ebola, as long as you have not got into contact with that person or the body fluids that come out of this person, chances are that you can't get the virus.
Thanks. I have another question from South Sudan, and two questions from South Sudan, and I'll ask in this order. First of all, here's a question. Ebola has been killing people for years. Why is it that there is no treatment for it?
That is an interesting question. I think it is similar to a number of communicable diseases which we have had here, including HIV. I think if you have tried to read the strain that we have currently is the Sudan strain, the Zaire strain. Our colleagues, the US CDC, they have tried to approve some drugs for the Zaire strain. That information is actually available on the US CDC website. So for the Sudan strain, there is a lot of research that is still ongoing, and what's available now is provision of supportive treatments. So there is quite a lot that is unknown regarding the Sudan strain. But there is some good documented information on Zaire strain. Actually, most of the preventive approaches, measures, and information we are sharing is much more hinged on the Zaire strain. So I know that their research undertakings in line with trying to find out if they can get approved treatments for the Sudan strain or Ebola in general, and of course also in line with vaccination. I know that question may also come through. The number of ongoing research in regard to trying to get some vaccines that can be applicable to the Ebola, more so on the Sudan strain virus.
Thank you very much. Another question here. What support is given to Ebola survivors, especially those suffering from, and I'm going to mispronounce this, sequelae of Ebola virus disease?
It is an interesting question. It's actually, well, this week on Monday, we had a community baraza in the two districts where we have a partial lockdown. That's Kasanda and Mubende. And the community members were proposing that we give something close to 5 million Uganda shillings to survivors to kickstart them. But what we do is there's no any approved kind of fund. When survivors are being discharged from health facilities, after undertaking 2 Ebola tests, they are only being provided with beddings and some clothes to enable them go back home and kickstart. But what we have also now added on is the provision for food, because the World Food Program is supporting that component. So we are providing food for some of these people to be able to kickstart them with life in their communities.
Thanks so much. Follow up to that. What messages are you putting out to communities for safe burials?
Now, the announcement of the partial lockdown by the president has slightly made some things be handled differently, because previously the government was basically undertaking safe burials to only confirmed individuals or individuals who have died when we know what has killed them. But now in the high-risk districts, that's mainly Mubende and Kasanda, government is actually now, we are conducting the burials ourselves. Our burial teams are the ones conducting these burials. The essence is that we would like to use the 21 days of the lockdown effectively, but we have also tried to engage communities because there are a number of social, cultural myths, misconceptions, but of course also beliefs, norms and beliefs that people do a number of things to the dead. So we are trying to discourage them and trying to discourage the cultural practices on the dead people. It's one of the key areas which we are concentrating on even during now.
Thank you. Dr. Kabanda, there's a lot of questions about the name of this current strain of Ebola, Sudan. Can you, and also some confusion about what the situation is with vaccines. Can you update us on why this Ebola strain has been called Sudan in the first place? And what is the situation with any potential vaccine for the Sudan virus strain?
Now, we have a number of strains. We have the Bundibugyo strain. Those of you who have tried to read some literature on Ebola and how the genesis and why we have, for example, the Zaire strain. What happens is that naming is based on where they got maybe the first case, and our clinical laboratory teams, when they do the sequencing, they try to match these and see whether this is a new strain or this is already a strain that has been in existence before. So the Uganda Virus Research Institute in Uganda is responsible for that function. And you know that Sudan has had Ebola before, the Sudan strain was based on the fact that it was actually the cases were identified in Sudan. So, but of course, you know that in Uganda also, we had cases of Ebola some time back in one of our districts called Bundibugyo, and that kind of strain had not been documented anywhere else. So also ended up naming that as Bundibugyo strain. But the very common one is the Zaire strain. I think that's why there's a lot of literature and information about the Zaire strain. And I have talked about the issue of vaccines. We have had a number of engagements with our colleagues from US. And I have to tell you that currently there's no approved vaccine that is available for the Ebola virus. So especially the Sudan strain. But I will say that there are a number of research undertakings going on, and we are hopeful that the scientists will be able to reach some productive conclusion regarding that matter. So because we don't have vaccines, that's why it's very, very important for our people to focus more on prevention, because no treatment, no vaccine. So it means that the prevention part is what we need to put more emphasis on. Actually, that explains why I expect that maybe somebody will even ask why are we having the lockdown. That partly explains why we have the partial lockdown in place in the two districts, and that has been mainly hinged on the fact that people have been moving around. So the contacts have not been accepting to isolate for some days in their homes. They keep on moving. So some of them turned out to be positive while they traveled in Kampala. So that's why it was better for government within our public health measures to ensure that we limit movements for now, for some 21 days, and then try to see if we can be able to have all the contacts traced and monitored fully, and then ensure that there's no mixing of individuals. That way, we can be able to minimize infections internally, but of course also importing the virus outside Uganda.
Okay, you mentioned lockdown, and I think perhaps this question from Afita Isa is getting at that. Can you tell us what is being done in Kampala City to prevent the spread of Ebola?
Okay, in Kampala, those of you who have been trying to follow Ghana news, Kampala metropolitan area, that's Kampala and the two neighboring districts, Wakiso and Mukono, they have been taken to be high risk, given the fact that many people who travel from other parts of the country can easily come to Kampala. So currently Kampala metropolitan is into what we call the response mode. So we are doing we are preparing our structures. We are also putting a lot of emphasis on creating awareness and having a number of stakeholder engagements in terms of orienting them, educating them, and preparing them to be ready for any eventualities. And we have also tried to prepare isolation centers within Kampala, so that in case of any any suspects, we are able to, we have actually for now 3 isolation centers within Kampala metropolitan.
Thank you. Dr. Michael Gube, you have your hand up. Do you have a question at this point for Dr. Kibanda?
Yeah, Mike, thank you very much. I just want to raise some few points that we also hear from the media and the communication side. The number 1 question is, first of all, I would like to thank you for the very good presentation and informative one. There are case updates given daily, and probably now from the presentation also, you focused on confirmed cases. On the other side, you will have probable cases and cases. Now, I would like to ask, why is there controversy on the media sometimes that the numbers are high? Because media also is bringing some experts to talk about the initial phase. Now the numbers are exaggerated, and the reports from different sectors that we see there are numbers differing on the same date. For example, on October 17, in some places, you can see a number, another side, another one. Why do you think this is a difference? Because it creates a room for some sort of confusion and spreading some misinformation. Number 2, we see the level of stigma is very high, both on survivors and also suspected cases, not only in Uganda and in other areas also. What is being done to address that? Because this is the critical reason behind delayed health-seeking behavior and further spread, and also the cases, the challenge or resistance in the isolating oneself when case is suspected. Lastly, I understand there is a guidance on safe burials, SOPs, but in different cultures, we have different ways, where the deceased will be buried, a process like a prayer, religious community, as long as there's no contact or whatever it is. This is so vital and very important for people to have this service before a burial. I know this is a very area where there is maximum precaution is needed, because the dead body will have a lot of viruses, and definitely health workers are big. But the instruction that we are seeing is that everything has to be done by the health workers, and all the other senior attachments or feelings or emotions because of loss and the prayers and other things. How is it going to be, discussed with the religious leaders? Because the acceptance of this safe burial will be much higher if we incorporate some elements which are, as long as we make sure that the standards, precaution measures are observed. If we integrate and discuss with this, is there any discussion going on with the community leaders, or is it only the health worker? Any dead body has to be, we hear that, be buried by the unit from the health function. That will bring a lot of resistance. What is being done on that direction? Over to you. Thank you very much.
Thanks, Dr. Gube. Did you get those 3 questions, Dr. Kibanda?
Yes.
Okay.
Yes, I did. I'll actually start with the last one that is more interesting, that we have had some community feedback regarding our barrier teams. And that slide where I had the socio-cultural factors and why they actually leading to resistance from some communities. I didn't share the details of the report, but the community members highlighted that the way people are buried by the medical teams, the people are feeling that it's not proper. And of course, drawing lessons from what happened from Western Africa, we have been able to modify a number of things. So last week on Saturday, in our top management strategic committee meeting, we resolved that prayers can go on. So people can even give speeches, but as long as they are not in contact with the dead person. So our barrier teams will now, what our barrier teams are doing, or what they're going to be doing, because since that time we have not had any safe burial, is that the barrier teams will be carrying the dead body and already wrapped in the body bag and ready to execute the safe burial. But the members of the community or the family First of all, as we have developed what we call the standards for safe burial or procedures for the safe burial. And one of them include having an engagement with the family members and then an engagement with the community members. Then the other key issue is that families will be allowed to hold prayers and pray and have that kind of normal proceedings, which we have been having. And then later after, have speeches and then allow the burial teams to conduct this. So we saw it that it was actually leading to resistance. It's a good question and an area that we have actually now handled. The other issue about the controversial numbers, yes, I would say yes, because you must have seen this also happening within the WHO website. Our country, we have now resolved that we are not reporting probable cases because that we realized that it was bringing a lot of confusion. Even some people don't know what a probable case is and then a confirmed case is. So we said that, okay, these are probable cases, they are not confirmed cases. We should not be reporting them in our daily press releases. This should only remain among our technical teams. But what you need to know that the times have changed because of availability of social media. Even when you are having a virtual engagement with the technical teams to say, okay, this is a probable case, this is what we need to be able to do because maybe for do conduct listing, follow them up, and people take photos, people take screenshots. So it's completely difficult to stop individuals. So some of our colleagues eventually end up sharing this information, which leads to misinformation. But if you look at that slide and what we are now sharing on our official website and official social media platforms and our engagements with the media, we are only now reporting confirmed cases. The component of stigma, yes, initially it was there, similar to what we went through during COVID, for those of you who are part of the response. But what we have done now is that we realize that people, if somebody has been discharged and declared to be Ebola-free, communities take long to accept. And we have now put in place a psychosocial team. So the psychosocial team is supposed to prepare families and the community where this person comes from before the person gets back to the community. It's one effective way. And the other also way is to have that free interaction with them when they're being discharged between the medical teams and then themselves, and then also ensure that we give it media visibility.
Thank you very much, Dr. Kibanda. We have questions about misinformation circulating about Ebola, and I'd like to hand the mic over to Anne Gungera of Viral Facts Africa. This is a group that does a lot of research and tracking of misinformation about COVID and other health issues. Anne, do you want to ask your question directly?
Yes, thank you very much, Wayne. It's glad to be here. Thank you so much, Dr. Kabanda. Your presentation was very insightful. So I think I'll start off with a question for you. Because we are seeing a lot of confusion and misinformation about what happens when a patient is taken to an isolation center. Because we know we don't have vaccines for this specific species that is circulating in Uganda, and we also don't have like a specific treatment regime. So maybe could you give us like a brief overview of what happens when a patient is brought to an isolation center, like between the time they are brought and the time they are discharged, just before I now talk about what we've done. Thank you.
You know, there is a very thin line between isolation centers and holding centers. It's also different from Ebola treatment units, what is abbreviated as ETUs. So whoever goes to the Ebola treatment unit is someone who has been confirmed to be having Ebola. And then that is somebody who is receiving supportive treatment. So, and the procedures are different. Somebody is still in the holding center. That person is still under investigation and is being monitored as we wait for results from our laboratory teams. So when somebody is confirmed to be having Ebola, then somebody upgrades and somebody is being taken to the ETU, the Ebola treatment unit. What happens is that, of course, you know, between me and you, we know that if somebody has no signs and symptoms, however much, because some people present with signs and symptoms, initial Ebola presents the same way malaria presents. So some people get worried if somebody has some of those signs and symptoms. And usually what happens before the results, if there are many people in the holding center, or isolation center, of course, the tendency of giving space to the other person, which is actually right. Because what we are now trying to do currently is that if somebody is in the isolation center, we're not allowing them to mix up until when results actually come back. So because that's one sure way. But we have also tried to advance. We have proposed to have screens in place in ETUs and isolation centers to ensure that if relatives want to have an interaction with these people, they can be able to come and have that kind of interaction or see how their patients are faring. That's one of the key areas that's being undertaken.
Okay, thank you very much. So, Christoph, I don't know if you have the links for the videos ready, but as you pull that up and share the screen, I think I'll just give like a brief overview.
Actually, Anne?
Yes.
I think we're going to come back to that
Okay.
because we do need to hear from Dr. Ghebreyesus. So can you just hang on for another few minutes?
Yes, definitely.
All right, thank you so much. So yes, and thank you, Dr. Kabanda, for answering. I mean, I didn't get all of the questions, but there's just so many. But thank you so much for answering all the questions that we've given you so far, and there might be more. But we're going to switch tracks a little bit now because you know, as journalists, we have to be very careful. We have to be careful about people's privacy. And when dealing with something as dangerous as Ebola, which creates so much fear in society, it is even more important to be sensitive as journalists to how we report on this and how much information we give in terms of specifics. And to deal with that, with some of those issues, Dr. Michael Ghebreyesus is joining us again. Dr. Mike is a senior humanitarian project manager with Internews, the Rooted in Trust COVID-19 project from South Sudan. So he works closely with the RCCE groups in the country and works closely with journalists in South Sudan on their reporting on health emergencies. And so Dr. Mike, welcome back to the dialogue, and please go ahead.
Okay, thank you. Can I share my screen?
Yes, I think you can.
Yeah, okay. Let me know if you see it here.
Yes. Yes, we are seeing it.
Okay.
Thank you.
Okay, thank you. I would like to focus on this presentation data for journalists, what they need to know. As Michael, you mentioned, in relation to current context where there was a speech with the, because everyone is watching all the neighboring countries, what's going on. And number one, I will just try to clarify some of these points, what it means and how journalists should be careful in handling this information. What will be the potential consequences if we don't handle it? Before that, I will just I want to point out some, I mean, basic facts on what happens whenever there is any kind of an emergency, be it an outbreak or earthquake, what is needed, especially in the first months. Experiences in also in West Africa and other places have shown the response in the first months, and how you handle also is very important on how the better on efforts also to control the spread of EVD outbreak. So I will just put that one, and I want to show you what has been happening in the area of media communication or on the public feedback, online, offline, and also what are the other factors or controversies affecting or creating an environment for more rumors and misinformation, especially in areas where we have colleagues working in Uganda. Before I come back to any major areas and tips on how to handle in the initial phase and also in the gradual phase. First, I would like to point out some few figures. I think these figures are for related to, let me just minimize this. The EVD situation as of October 17, sorry for my repetition. I think more or less it has been described by the previous speaker, and I don't want to repeat much of it. And as you have seen, some people report, the cases and the probable cases. And as Ministry of Health of Uganda explained, we will be focusing on more confirmed cases. And so we will just take note of that, but maybe we need to see what's going to happen in future if there are any increase in probable cases or improbable cases, especially when someone has a contact was not confirmed. We have, a very active preparedness activities going on in the neighboring countries. I want to mention in South Sudan, any alerts are going to be immediately responded, but the biggest challenge we have, for example, is the turnaround time for testing. We have suspected cases reported widely in the media times, and it takes nearly now the last 2 cases sent to South Africa for testing has not yet arrived. It took like a week. So there is always tension building in between until the results come, especially in the communities around where there is suspected case. So there is big gap in information and climate of fear and panic evolving as we wait for results. I just want to see basic facts and what should be done in the first. If we understand these basic facts, then the reaction, what should be the right way to address this will be a bit clearer. Definitely, whenever there is a disaster, whatever earthquake, or be it like epidemic, and then definitely there will be a climate of stress, anxiety, panic, fear of the future. It is understandable, and especially in diseases of poor prognosis like Ebola virus disease that we see compared to other illnesses, then it is this climate of fear will be more aggravated. So what exactly do we need to do for people just to think about how to protect themselves? What is the government doing in terms of protecting? Not only giving the numbers. The numbers are so important. People have to know, citizens have to know the cases, because they understand that there is an imminent risk of this disease. And also any risk perception will help positively to alert people and take measures to engage in preventive measures. Beyond that, all these controversies, all these issues will not be much helpful except aggravating the panic and also climate of fear. So this is the initial phase and how we should react. I will come back to you what has been going on in relation to this. How did we address it as a media, as public health, and other places? Secondly, it is very factual that people will have a direct and strong need for information. What happened? Who is affected? How can I protect myself? A number of questions do they come. Is it like airborne? Because if you feel people are confused that this is an airborne disease, how will they react? They should run away, or they feel like deserting some places, and a number of critical and vital information is needed here for people to understand and handle this. Definitely risk communication, as our colleague said, that it is a vital any disaster, be it disease outbreak or anything, and especially currently, the prevention measures are so important in an epidemic where there is no vaccine or drugs to treat. So, and also the media is something important. Now, having said this, what did we see? I mean, in the first phases, and I will come back another slide related to what are the exactly the controversies and some points that we were able to capture regarding the president's speech too. Now, there were some observations on social. Definitely, we understand there is a still continuing climate of fear and apprehension, especially in areas where confirmed cases are reported. In the beginning, even the Minister of Health were advising citizens to stay put and stop running away from places where cases are, suspected cases are coming. There was a lot of reaction. Now we see continuously the media disputing the official number of cases reported. At times, they say it is exaggerated nowadays, and also in the past, then they say the number is somehow higher than what is officially reported. And the issue of someone being bewitched, and also some information that, I mean, it's a ploy to get money from donors, or the Ebola situation, a diversion from social economic group. A lot of misinformation is going on. In the neighboring countries also, for example, I will show you, the media is using, any suspected case as a breaking news. Let me show you something. For example, look at here. Now, this is one reported, breaking. One suspected case of Ebola reported in Mule border of South Sudan, health authorities confirmed. This is like a breaking news a media is reporting. And there is another serious misinformation. You see, the National Ministry of Health says one person suspected of having contracted Ebola has died in Kajukeji County, Central Equatorial State. 5 suspected cases have been, 3 samples have been collected and taken to South Africa. As to now, there is no any confirmed case. But that time, just 2 weeks back, there was a report that this was one of the major radios, South Sudan, that suspected a case of having contracted Ebola. I mean, you cannot confirm unless you take a sample, take the blood, and make sure that this is a confirmed case. This is the only way you say that this is a confirmed case. So, I mean, these are a lot of breaking news confusions that result in a number of aggravating the panic and also aggravating the stigma. I mean, in neighboring countries, I mean, like this, suspected cases reported COVID without any confirmation, reported EVD cases without confirmation is bringing anxiety. In some places, people are asking, fear of virus spreading and demanding border closure. What we see also in South Sudan, what's interesting is that in 1976, the Sudan variant, when it was named, I think Sudan and South Sudan were in one country, and that's where cases were reported, and some cases have. Now they say this is a virus that we know before, and we will defeat it like COVID-19 again. This is something that generally, at times we hear on social media. Now coming back, other mode of responses fueling rumors and doubts. I mean, for example, there is a number of measures that are taken in Uganda. I mean, there are some politicians on record claiming that the security deployment is instead being used to intimidate, incarcerate locals, and someone has to pay this to go out of the police. And also on social and online media, the president has not been given full information on the outbreak. That's how the speech was interpreted. Foreign countries put pressure on the government to stop the spread. That is why the lockdown has come. Public questions on contradicting figures, MOH, local official, public say, and I just mentioned. Sections of the political Ebola outbreak is being used for financial gain. There are questions by politicians and public as to why not redirect resources to the medical response instead of security deployment. There are rumors that communities are using porous district borders to move between the restricted areas. Anyway, on the whole, I think the speech has also, and the lockdown measures, which we may just think about and further community feedbacks can tell us, has brought a number of issues circulating on social and online and offline media. Another important point that I would like to mention from the president's speech is definitely we communicate the risk. We give the numbers and update for everyone to understand them and the the presence of risk of an outbreak and how to prepare, protect themselves where it is. So at least downplaying whatever, providing actual factual information is one thing. That is what is needed. Risk awareness is so important. I mean, but downplaying in general at times may take down any feeling of, perception of risk, and will be difficult in our preventive, challenge in our definitive efforts. And another thing, in one way or the other, wherever any suspected case, unless proven otherwise, as I have said, there will be a lot of cases of malaria and similarly acute febrile illnesses that we may see. And the initial phases, it is so similar. Even we are seeing that one of the symptoms that we see at a later advanced phases, bleeding from here, it is not seen in much of the cases. Today it was reported, I think around 1/4 of cases are showing that, but it is just like this. And anyone having this, especially with someone contact, should go to the health facility and report. In a climate of stigma where anyone, be it a survivor or suspected case, the stigma definitely is against any public health preventive measures, and also, especially early seeking health behavior. Now, in the president's speech, I think a number of name, village, age, and then even the family members and a number of people have been mentioned, and the whole family, and what has been done. Okay, this is not like a criminal or another investigation. This is not something else. If it is an example to mention that what should be done and what should not be done, it can be said without naming people, without doing this. This is, a case-oriented, what people should not do. If you do this, then things will just escalate this one. But naming the families or a linkage will definitely aggravate, and it is just like a big challenge for communities. And as our colleague said, even those who survived are facing a very difficult time in getting acceptance, and a lot of work has to be done. But directives targeting the specific family and telling them to cooperate with district officials. And also, definitely, this is also another factor that will definitely play a negative role. I would like to just mention, in every community, as our colleague earlier said, there are practices in dealing with epidemic management, because with the modern medicine, before even it came 100 years ago, people have been practicing. In South Sudan, we know what kind of disease epidemics to come. The community leaders, traditional leaders, and they are involved. What they need is more knowledge. They should not be resistant. Once they know once you know the benefits, who would resist? And people will be more accepting this. These are influentials who influence the community, and influencing these influentials is so important to go into it. So telling any witch doctor, traditionally herbalist, any religious leader, okay, it is good to advise them to cooperate, but in all the steps of prevention and also early seeking behavior and also safe burial, their participation is so important, and it is so very good to engage. It is so important, all these influentials to do on all this. I don't know, Michael, how much time I have, but I just have a few slides more.
Dr. Ghebreyesus, as usual, we've run out of time again. I'm sorry. Can we come back to you in another week to talk to you again about this? There's one more question in the queue, and I would just like to get to that question, and we'd also like to show a viral facts video. So, okay. So thanks, Dr. Ghebreyesus.
Yeah.
Thank you.
Thank you very much.
All right. Thank you. Now, there's a question. Sadaraka Dominic, you have a question. Is it for Dr. Ghebreyesus or Dr. Kabanda? And would you like to ask it? Or type it in the Q&A box, whatever your preference.
No, I don't have question. Maybe Dr. Ghebreyesus.
Okay. All right. So yeah, unfortunately we are running close to end of time. I just want to bring back very briefly Anne Ngara of Viral Facts Africa, and we have queued up one viral facts video that we have time to share. It's on Ebola origin and naming. Would you like to briefly introduce it?
Yes, thank you so much, Wayne, and I'll do that very fast. So that is a question that I think I've seen in the chat as well, and it is a question that we kept seeing in the social listening reports that we usually do weekly. So people did not understand why is it called the Sudan Ebola virus. So we just did a short video explaining the origin of Ebola, because you need to understand the origin of Ebola for you to understand how the naming came about. So if you could please play it for me. Thank you.
Ebola is a rare but deadly disease. The current outbreak in Uganda has been attributed to the Sudan Ebola virus, which was last reported in the country in 2012. A few of you have asked why it's being referred to as Sudan Ebola virus, so here's a little history about Ebola. It was first discovered in 1976 after 2 consecutive outbreaks in the Democratic Republic of Congo, formerly known as Zaire, and present-day South Sudan. The first outbreak occurred in a village near the Ebola River in the Democratic Republic of Congo, which gave the virus its name. There are 6 species of the virus, each named after where it was first reported. From the available previous outbreaks data, the Sudan species seems less transmissible and less severe, with a lower death rate ranging between 41% to 100%, compared to the Zaire Ebola virus, which has a death rate of between 70% to 100%. There have been 7 previous outbreaks of the Sudan Ebola virus, 4 in Uganda and 3 in Sudan. WHO is currently working with health authorities in Uganda to ramp up detection and track contacts to control the further spread of the virus.
Yes, so thank you very much. That is just one of the many videos that we have produced. Someone also asked about how it is spread. That is also the first video we produced. And I think, thank you, Christoph, for sharing those videos in the chat. So yeah, we have been responding and just responding and sharing answers to the questions that we are seeing. So things about how it spreads, how you can protect yourself from this particular species that is circulating in Uganda, and also questions about its origin. We are also now working on something about vaccines, which should be out soon, and also something about the burial practices, because that has also been very controversial. Just to explain why it is very important to follow the stipulated health guidelines that Dr. Kabanda was talking about, so that you don't expose yourself further. Because one thing that people don't understand is even the deceased still have very high levels of the virus. And it is very easy for people to get infected if they do not follow these recommended public health guidelines. So we are also working on these things, and also debunk, explaining that the Ebola outbreak is real, which of course will go hand in hand with this explainer on how it is transmitted, because sometimes there's this misinformation because people don't understand how some of these diseases are spread. So when you create awareness about how they are spread, people are then able to know, oh, okay, then this could actually be true. So we are working on that, and we are of course going to share it as soon as they are approved. And thank you so much for having me.
Thank you, Anne, for that very valuable input. And as we prepare to wrap up another media dialogue, I'll let you know that we will send the recording of this dialogue to everyone who joined us today. We'll also send some audio excerpts via WhatsApp to our WhatsApp network. And as always, we'd like to hear from you, the journalists, on how you use the information that you get today in your work. And even better, if you can send us some examples of your work, we would love to receive those. So please just keep that in mind. Thank you so much to our speakers today, Dr. Richard Kabanda, Sylvia Samariva, and Dr. Michael Gube. Thank you so much for joining us and spending so much time answering all of our questions. And until next time, for the RCCE Media Working Group, I'm Wayne Sharp saying thanks for joining us, and please everybody stay safe.